So welcome back. This session is led by Marissa Eyanson again, along with Dr. Derek Hess, Clinical Director at HHS, Stephen Slye, and Michelle Vore with Flowstate Health. Flowstate is a national leader in bringing innovative approaches to addiction and mental health services into jails. Flowstate serves all 99 counties, including 57 county jails and 33 critical access hospitals with specialized programs for children, seniors, and statewide partners. Their work highlights how evidence-based, people-centered care can improve outcomes and reduce recidivism. So again, Stephen Slye is the founder and CEO of Flowstate, and Michelle is board-certified psychiatric mental health nurse practitioner and the chief operating officer of Flowstate Health. And Dr. Hess is the clinical director for the state of Iowa's Department of Health and Human Services and an adjunct clinical professor with the University of Iowa Hospitals and Clinics Department of Psychiatry. So please welcome them.
Hello again. So I know, I'm looking around, I have folks out here that are, somebody is a friend of Abby Ferenzi. I want you to see, well, here's the thing. I'm trying to figure out, we need to get a hold of Abby, so maybe somebody can send her an email because I think she forgot her phone, you guys. And so I'm looking for, somebody send an email to Abby. If you will raise your hand and tell me that you can do it. Thank you, Leslie. Because that way I can go ahead and start talking. Yeah, I know. And so also maybe include Aaron. I think they're together. So if we send something to Aaron and Abby, then hopefully we can find them. Because I can't send her a text. There she is. Abby, hi. I was trying to crowdsource finding you. We've got your phone. And I was really worried about it, because if I don't have mine, then I panic. I don't know what I'm doing. All right. So, as we were talking in the last hour or so, we've been thinking about we're building a new system. And one of the advantages of the system build that we've engaged into is it's given us this opportunity to really look at the work in a really deep sort of level and start to create targeted spaces that we can dig in together to do better. So these are those spots that would have been impossible for us before. The statute itself was in the way. The organization of effort was kind of misplaced. It wasn't because nobody was trying, right? People were trying really hard. People on the ground are still trying really, really hard. It was because we lacked the ability to organize the effort into a way that we could do better. So one of those really, really cool opportunities that we're here to talk to you about today is jail-based behavioral health services. Beginning at just about a year ago now, Director Garcia and I started to have some conversations with the Iowa State Sheriffs and Deputies Association. And one of the things that came through loud and clear to us was they were worried. They were seeing people in their jails, and they were very, very sick. And they were often trying to do that work with at least one, if not both of their hands tied behind their backs. There were spaces within our regional system that we had established some work related to how we think about mental health care in jails, for instance. But it was not working in the ways that it needed to all of the time. And at the local level, it wasn't really delivering what sheriffs themselves were seeing, what jail administrators were seeing within their jails. And so we really took it on together. I was like, my God, I've never worked in a jail, first of all. I don't know what that looks like on a daily basis. I can't alone, sitting in my office at the Lucas building, design something that's going to work. But I'm not too bad at paying attention to things that are important. And so we sat down with them over and over and over again, and we listened and we paid attention. And I have the advantage of having Dr. Hess, who's a forensic psychologist and has some background space of having an understanding. And then we hired Dr. Teresa Clemens. And my goodness, she's got some great background as well. And we started to talk to some of our providers who are doing the work. So this is really kind of our story about why. Why did we do that thing? What are we doing? And we're going to get to eventually what it looks like a little bit. So when I think about this work, one of the things that came up in some of those conversations with those sheriffs and deputies, for instance, was they were kind of excited for a minute, and then one of them raised his hand and he said, but Marissa, if we do that, right, if we build something like this within the jails, isn't that just going to reinforce this idea that people with mental illness are criminals? Or is it going to make it so that in order to get to gold standard of care, you have to be arrested? And the answer is, my gosh, no, right? That's not what we want to do. So how do we make sure, as we think about like building something that is the right thing and a really good thing and a true thing, that we're also guarding for stigma is something that's very, very powerful. We don't want to criminalize mental illness, for instance. That's not the goal. So there's a handful of things that I want to hit at the top. And the first is that you have to tell the truth, right? And I need all of us to work together to do that thing. And telling the truth means that we have to say it out loud that crime isn't caused by mental illness. That's a fact, right? But it is also a fact that there are a lot of folks who are going to be in jails who are suffering from some sort of behavioral health condition. So those two things exist, and they exist together. We also have to build parallel services outside of jails, as you heard us talk about in the last hour, and as you're going to kind of learn as you dive in deeper with us along the way. We're doing a lot of work simultaneously. This is one project, ultimately, within a portfolio of work that we are doing to improve the systems of behavioral health in Iowa. It's an important one. It's not the only one. Remember, our number one priority emerged as prevention and early intervention work, for instance, and how we do that work better to catch people sooner, and hopefully maybe they don't land in jail in the first place. We have to do all of those things with an equal amount of force and effort in order to build something that's truly systemic. We also have to talk about our successes and be brave enough to tell our stories, right? We have to say those things out loud, and we have to measure them in the outcomes data and really prove the effort. Sometimes when someone who is sick has also ended up in a space where they've gone to jail or they've been arrested repeatedly, we begin to view them through a different sort of lens. We begin to think that it is the way that they are. We begin to think that the crime itself is the mental illness, and we kind of confound the things. What we have to point out is that recovery is not only possible, it is the expectation. The installation of a model that does better by people who happen to be in jail, when we think about behavioral health work, is a way to be able to both honor that, but it's also very pragmatic. Over the course of time, preventing folks from cycling over and over and over again leads to better outcomes for public safety. It leads to better work that's happening within the jails, safer work that's happening within our jails. It leads to better human outcomes for the individual, and ultimately costs our entirety of our system less money. It's actually a cost saver. It's a cost avoidance mechanism. And we have to ultimately place the responsibility where it belongs. Oftentimes, these really big problems are the result of long-standing systemic issues. They're not individual failures, right? We can't treat a systemic issue as an individual failure and expect a better outcome. We treat individuals, we change systems that fail. We have to be able to do both of those things together in order to create something that's better in the future. That's what we're taking on. So why focus on those behavioral health services in jails? Well, as we all know, resources are incredibly strained. What we also know is that the effort that we've had thus far has really been kind of the epitome of doing the best we can with what we got, right? We're kind of scrambling things together in the very best way that we can. We've got somebody that we call, and every so often they kind of swing in to help, that sort of thing. But it's not designed to be that way. We've led to a space where we had a lot of misplaced precision. We focused a lot on coordination and less on services, for instance. And a focus on coordination is important, and it's going to be a core part of the model when we talk about building jail-based behavioral health services, but coordination alone won't get people better. It won't keep them well either. So we have to get to a spot that we can acknowledge that what's happening isn't acceptable for any of us, right? Individuals are sitting in jails and they experience withdrawals without titration. They go through alcohol detoxification. They rapidly decompensate into psychiatric disease. That's not acceptable to any of us and not the intended outcome for any single person in our room today. The difficulties then encountered by folks who are working within our jails and their staff as they're trying to ensure basic safety across populations of people who might be incredibly sick is also not acceptable. They should be safe, and they should know how to do their job and have the tools that they need to be able to do it. It also delays justice. Because if those folks are also in a space where we need to restore competency, for instance, but they're decompensating further while they wait in jails, then we're delaying justice, and it might happen over and over and over again. Those aren't acceptable. Those are systemic failures. Those are things that we can correct. So this work is ultimately about building jail-based work. This is important because jails are a concentrated area of need. We know that the Bureau of Justice Statistics tells us that about 65% of people in the jails meet substance use disorder criteria. That means that when we screen them at the door, we should expect to find over half meet the criteria for substance use disorder. We know that a similar number are going to meet that criteria for mental illness as well. And a smaller number for serious mental illness. 15 to 30%, that number tends to waver. We also know that doing this work is ultimately, when we think about behavioral health care, behavioral health is public health. Because ultimately, the provision of behavioral health is a space that you dig in from a public health perspective and really start to link to the improving safety mechanisms, right? We improve safety in our communities by improving people's individual health and wellness. I mentioned before, it's cost effective. When you do something in a way that's scrambled, right, where you get to a lot of administrative pressures and a lot of people running around doing the very best they can with what they have, you create both competition for resources and significant systemic inefficiencies or complete lack of systems. You create a hero effect. And ultimately, heroes can be pretty expensive for two reasons. First of all, they can just be expensive. Individual human level effort without organization, it's a lot of time. Second of all, if you lose the hero, the whole thing falls to hell, right? It's gone, right? That's expensive. And then also, in order to be able to do that, you end up in spaces where you're gonna miss everything else. So whatever time the one hero spends doing their hero thing, they miss all of the other things that probably should also be happening, and then those things become a lot more expensive too. Organization of systems, really being able to direct things from a kind of more macro perspective and then ultimately deliver what's needed, creates a cost efficiency for all of us, and then helps us leverage the dollars that exist today to make sure that we're returning an outcome that's satisfactory. And then we talked just a bit, improving health and well-being, of course, is at an individual, community, and statewide level. When people are better, they do better. End of story. That helps all of us do what I think is probably the reason that we mostly show up to work every day. So the model that we've been looking at as we've thought about how do you develop a jail-based behavioral health service model, because we don't have a model, right? So we started to develop what would that model be. We listened to that feedback that we were getting along the way as we were having all of those community conversations in the process of developing a statewide plan, for instance. We listened directly to that feedback that was coming to us from sheriffs and deputies. We talked with people that had had lived experience, and they told us about things that they wished could have been better. And we started to really hone into, there must be some other spaces, right? There must be something else to look toward. So there are other states that have developed some work related to the delivery of jail-based behavioral health services, and we started to really look toward them. There's some modeling in Colorado, for instance, that we looked at. And there's some modeling that came out of the state of Ohio, and there's a little bit of something that they built out in Oregon. And we started to look at what was really working and what was proving out in those spaces. And what it really boiled down to is that it, first of all, wasn't super surprising. Screening, assessment, diagnosis, and treatment. Those four things have to exist. You have to be able to screen in, screen out at jump. You have to do it fast because people aren't going to stay in jail for very long. When somebody screens in, you have to be able to assess them, and that it should be clinical in its nature, that we need to be able to have access to clinicians on a regular basis, and that they should be doing a protocol sort of space within the assessment, clinically driven work. Ultimately, what we also saw is that when states install this sort of mechanism, they find that there are a lot of people coming through those jails who have historically been untreated or undertreated, meaning they had screened or assessed for something, but it wasn't the right thing, right? So assessment leads to diagnosis, actually getting to very clear, true, good clinical diagnosis, informing a treatment plan that we then follow up on by establishment in the jail. And then all of that is circling around the idea here of connection to care, because the place that it breaks is when somebody leaves. During the time they spend in jail or any sort of correctional environment, we have a person. And we have the ability to do this work, ultimately, while they are kind of a captive audience with us. Now, they may tell us no, and then that gets off into a whole other space, don't get me wrong. But as long as they're willing, or we can get them to be willing to come along with us, we have them for a little bit. But if we don't continue to do the follow-up, make the connections, make sure that they have what they need as they're leaving the jail, the whole thing will fall apart. Because part of the reason, very likely, that they've come to jail in the first place is they may not have the capacity to fully, say, manage their life and their treatment protocol. They probably need some help to do so. They need the connections to aftercare. We need to make sure that they've been connected so they're able to get their medication filled once they're released, for instance. We make sure that they have an appointment established. We connect them with a CCBHC who have the ability on the ground to do wraparound care. We use that system navigation space to make sure that within the jail itself, if this is a person who's come in and what they actually need is connection to benefits, for instance, or connection to where they're headed or where their provider is going to be because they've never had one before in their life, we make those connections here and we do a warm handoff ultimately, to the other side, to the community side. And what we're trying to do is break the cycle. It won't always work. Sometimes people are real sick. Sometimes, even if we get people well, they still commit crimes because they're not the same thing, right? But this is our best shot. This is the way that we ultimately start to bend the curve. When people need treatment, we get them treatment. And when we get them established in treatment, we continue them as we go forward. The other piece that kind of really emerged to us over time as we were looking toward how could Iowa do something, right? Just do something. That became sort of the mantra as we were making our way, is that ultimately, even though it's kind of boring and it's kind of nerdy, system building matters, right? It gets us away from the hero effect, right? It gets us away from those spaces that maybe we've been stuck and gets us into how we look at things from a systemic perspective and make sure that we're pulling all those levers in the right direction. Good system design does things like reduces recidivism or stabilizes the behavior within the jails. It means fewer law enforcement encounters on the other side. If I stabilize my people, if I have less recidivism, I have less need on the other side for law enforcement intervention over and over and over again, those folks that I pick up every weekend. It builds out that continuity of care space, which is really crucial for folks with serious mental illnesses in particular, because when folks decompensate repeatedly over the course of time, they can suffer permanent space there where they don't fully come back. So every time we let them go, every time they decompensate, we're running a risk that they're going to get sicker and get stuck, and we may never get them back. And it ultimately is strengthening our social safety net by putting things in the places where people need them most. Now, when we don't do a systemic design, when we rely on heroes, when we don't do an organization of our thought and our effort, what we can ultimately get is Band-Aid care, no continuity. We can do a heck of a job in the jail, for instance, but if we don't get to a system design to pick a person up, then that would kind of fulfill that prophecy of, oh my gosh, what happens if we create jails as the gold standard of care and then nothing else exists? Well, no care continuity means what's going to happen? They are going to come back. It becomes over-reliance on jails as a hub for treatment. It can mean inadequate staffing or training. It actually worsens that stigma space and then particularly mistrust, because now you get to a space where you're going to run a risk that folks are going to view the behavioral health space as punishment. Right? You don't want to do that either, because then they're going to kind of opt out. They're going to opt away from it. And it also becomes an incredible resource drain. Right? If you build something so that it has all of these walls in front of it that demand that you have to cycle through a legal system in order to access care, the drain on resources is incredible. We see that sometimes. We see it today. And we could make it worse if we're not thoughtful about the installation. We have funding that existed prior state. There was work that was happening. There was a lot of work that was happening to try to connect people in jails to what they need. And what we saw was that there was a lack of balance in how we were contemplating the work. So we were really heavily invested in our regional systems, for instance, into the service coordination aspects. And part of that was because historically this is part of the crucial focus of work that had happened within MHDS regions. And we only had one tool, and that tool was service coordination. And we viewed everything through the lens of service coordination because it's the one tool we had. And what that meant is we became overinvested over the course of time. Overinvested into coordination, underinvested into services, because there were too many hurdles in our way sometimes to be able to get to the services space. And service coordination was the one thing we had. But what we get in service coordination isn't clinical. It didn't get us screening, assessment, diagnosis, and treatment. It didn't always get us the connections to the aftercare or the benefit management spaces that we're looking at from a system navigation space, although people tried their very best. So when we think about the dollars that are available today, we're thinking about writing the scales. How do we think about capacities and resources so that we can focus more of those dollars into the services themselves? And then also make sure that we sustain that coordination of effort is a crucial component, both for the work that's happening when someone's within the jail itself, but also as people are going to release, because those folks are coming home. And we need to be able to do them both. So this is how we start to think about reinvest, right? We have some significant administrative savings, and the way that we're building some of this work, when we think about the school-based work that I talked about before, the jail-based work that we're talking about now, is we're reinvesting savings from administrative savings that come from Our prior state was administratively burdensome. You heard some of our providers who are still just kind of giggling to themselves on occasion. They're like, it's so much easier. Yes, it is. That's on purpose, and that is saving the state of Iowa a significant amount of money. Right? It's easier for our providers because you do the service, you should get paid. It shouldn't be so dang hard. We can make some of those things work better. And we have fewer people passing papers around in order to get you paid in the first place. That's administrative savings. We save approximately between both a behavioral health and a disability services bill, just in administrative savings alone. Our estimate this year is that we'll save over $3 million. And the entirety of the $3 million is reinvested into services, with a significant component here in jail-based work and another significant component in school-based work. This gets us things we haven't had before, and that is incredibly exciting. Now, Dr. Hess, there's a duty to treat in jails that you're going to talk with us about as we start to think about, we have a why, we have a model, what's our duty?
Thank you, Marissa. So to kick this off, I want you to think for a second, in your head, you don't have to talk out loud. Who in the United States has access to universal health care? It's not us in this room. It's not older adults who might be eligible or receiving Medicare. It's not individuals who have lower economic status who might be receiving Medicaid. It's individuals who are detained in jails or individuals who are serving sentences in prison. The reason for this is because of this landmark decision from the United States Supreme Court in 1976, known as Estelle v. Gamble. This was a decision that found that jails are obligated under the Eighth Amendment to provide inmates with adequate care for, quote, serious medical needs. Serious medical needs include serious mental illness. Not necessarily just serious mental illness, but other types of mental health or behavioral health conditions. And so this is something that's been in existence and around for a long time. It's a fundamental right, and it applies, therefore, talking about duty and therefore burden, it applies to all jail staff across Iowa. It applies to all prison staff in the Department of Corrections across Iowa and other states in America. And the thing that we really care about here is, the reason that we care about this is, one, because it provides that right. It provides them access to care. And it says that there has to be, for any care ordered, there's judgment that happens within this space and within these teams. And if we're not following certain courses of judgment or decision-making, we can get sideways. Not only can individuals in our care get hurt or die, but we can be liable financially or otherwise for those harms that occurred. So when we break this down, I threw out this phrase, deliberate indifference to serious medical need. There's two phrases of it, and we can bucket them or bifurcate them into two different buckets, and they mean different things. So the deliberate indifference side of things, that's the jail or carceral setting staff, right? That's the employee that we're talking about. Serious medical need is the inmate or prisoner or defendant in that case, right? The individual that we're caring for. And when we look at the deliberate indifference side, that's a real subjective standard, which means that the individual staff member, say at the jail, has to have some actual knowledge that this inmate has some sort of a serious medical need. Now, as Marissa said, if we know from statistics that about half of anybody who crosses that door into jail is going to have a mental health problem, we actually think more than that, probably upwards of 60% are going to have a substance use issue, right? And about maybe a quarter, 30% may have a serious mental illness. We know from the jump that if I do nothing but flip a coin, about half of those people that cross that door are going to have a condition that falls in this bucket, right? So if you're going to default to something, you default to the presumption that they have a serious medical or mental health need in terms of concept. Now, this deliberate indifference standard really is, it is subjective, but it's between what we call negligence and intent, right? Intent is, I wanted to harm this person, or I wanted this person to kill themselves or hurt someone else. Versus negligence, which is much more of, I should have known, but I didn't, right? You hear about malpractice cases for medical issues. Someone leaves a scalpel inside someone during surgery, or a sponge, right? that is likely in the negligence camp because they knew better. They should have known, and they should have had process and procedure to make sure that that doesn't happen. Someone messed up. That's more likely in the negligence camp. Whereas intent is what we hear more about for like intentional crimes, let's say murder or rape, where I intended to cause that harm that was done in that space. This is really in the middle. It's referred to as recklessness. So there must be some level of reckless disregard for this substantial risk of harm that the inmate was experiencing or might have experienced. So it's that staff knew of and disregarded some excessive risk and didn't take reasonable steps to decrease that harm. Right? This includes ignorance. We cannot just ignore information. So if we have, let's say, Flowstate or another telehealth provider coming to us and saying that an inmate has a certain diagnosis or needs a certain medication or a certain observation or a certain lab or a certain check, we can't just bury our head in the sands and pretend we didn't hear that. We can't do this, right? Now we know. And so to disregard that is probably, all things being equal, creeping us toward that level of recklessness, depending on what's going on. The other side of the bucket here is the serious medical need. This is the objective standard, right? So this is more neutral. We would all get in a room and hopefully be able to agree on what things, what diagnoses, or what presentations, or what symptoms actually mean a serious medical, or in our case, a serious mental or behavioral health need. And there's really a three-pronged test that we use. We look at one, symptoms. We look at the etiology or cause or drivers of those symptoms or issues. And then we also think about what available treatments we may have in that space. So it's not based on any one of these things. It's really based on all three of those spaces. And so when we think about some examples, I just throw these out to you again to think about in your own mind. Do these things strike you as serious medical needs? Inmate diagnosed with a schizophrenia spectrum disorder, paranoid schizophrenia, schizoaffective disorder, for instance. What about someone who's diagnosed with bipolar I disorder, experiencing significant manic or depressive symptoms, often a lability with a lot of high-risky decision-making in the process? What about antisocial personality disorder? For any clinicians in the room, that might be the first one that triggers well, wait, that's different than the other two. Because those other two we often think of as serious mental illnesses, no real questions asked. We don't always think of personality disorders as serious mental illness, but I will tell you clinically, if it's severe enough, I think it counts for these spaces, especially like borderline personality or even antisocial. Not everyone who's arrested or convicted of a crime has antisocial personality. It's important to keep in mind. Even if you might be able to factor in that they meet that criteria, is it the spirit that they really meet, even though they're causing illegal acts? What if they're intoxicated or withdrawing from alcohol or other drugs? Here's another one that might be a little unique. What if they're diagnosed with gender dysphoria or they identify as transgender in the space? Does that count? What if, throw another wrench in there, what about if it's an intellectual and or developmental disability? They may have a mild or moderate ID. They may have autism spectrum disorder, for instance, or something along those lines. These are all different clinically, but do they all meet this threshold of serious medical needs? What do we think? Definitively, it's a yes. There we go. I don't know if that's ever going to stop, so I'm just going to ride this out for a minute because I think that's kind of fun. They all are, right? Now, to give you a little bit more fodder and information to, I get it. He said that those labels are, but how do I know? How can I, if for any jail staff that are in the room or others working, if we have these other providers who are working with our jails and our jail systems, how do we know? Well, these are all things that, again, if you add them up, are going to lead you to the decision that, yep, this is objectively a serious medical need. If you have things that are diagnosed by a clinician, if you have symptoms that are affecting their daily functioning, are they preventing them from taking medications, from getting along with people? Are they throwing feces and fecal matter or other things in their cell or otherwise very disorganized? Are they harming themselves in some way? Are they harming others in some way, often physically? Or is that likely to develop in the future? Would a reasonable professional think that this individual, what their presentation is what they're presenting with, is important or worthy of comment or treatment? Is it something we care about? Do we think it's needed to focus on to help that person get better and be healthier? Does it produce a chronic or substantial pain internally? Mental illness is really, really painful for many people. There is an angst and a physical pain. There's a reason people, especially with serious mental illness, have such lower life expectancies than their non-seriously mentally ill peers. It takes a toll in many ways, not just emotionally, but obviously functionally. Is the disorder so obvious that even a layperson would recognize that something's off, something's right? They may not know what it is, they may not be able to label it or diagnose it accurately, but if they'd sit there and say, yeah, they're not right, they're different than all of these other folks we see every day, that in and of itself should give off that ding, that light bulb of, all right, we probably are in this arena here. And last but not least, would failure to treat that condition, those symptoms, that presentation, result in further significant injury, again, themselves or others, or unnecessary and wanton infliction of pain? And this is where, again, the Supreme Court of the United States has said, if we do not respond to these needs, we are inflicting cruel and unusual punishment on someone who's in our care. And so despite all that, why do we really care about this? Well, there's many reasons, as you can see. One, as I mentioned, it's a constitutional right that we can't ignore, even if we haven't realized it until, say, maybe today. As Marissa was indicating, and I think as our Flowstate colleagues will talk about, it really helps us having this mindset. Again, if you approach that the idea is my default is going to be that everybody who walks in my door, the majority are going to have one of these issues that I need to help them address, you are now a change agent. You're a problem solver at helping that person and everybody else in the system, your jail colleagues, other jails, other systems of care, to actually see improvements, have better quality of life, better use of fiscal financial resources, probably less burnout. And as Marissa mentioned, I think this is really key to stress, because I think in our process over the last several years, there were a couple meetings where I, for instance, had a light bulb went off in my brain about, I see where this tension is between law enforcement and hospitals or emergency rooms or clinicians. We're both talking about dangerousness, but we define those distinctly different, because they mean different things in the law enforcement world versus the hospital or clinical world. And so I think it's really important, I'm so glad that Marissa mentioned it, this idea that jails right now, and I would say for the reasonable foreseeable future, I actually don't know when that end date is, probably not in our lifetime, you are an intercept for these issues. You are an access point for these issues. You're a liaison, you're a hub. And being those things does not make you the end-all be-all. It is not embracing that position and that responsibility is not going to lead more people your way. No. If we handle our business collectively, we will set up other processes and procedures to make sure that that doesn't happen. But there's no way to unkink the hose or the bottleneck unless we can ensure that people who are in jails or in prisons are getting high-quality care to address their needs. So they can then hopefully, if they're in a jail, for instance, and they say they're not convicted, or when they serve their time, they're able to then move on or get connected into other spaces. We know about the high rates and the disproportionate impact that individuals with mental illness have in these systems. We can track it very, very clearly back to the deinstitutionalization movement and how when people flooded out of our institutions, the money and the resources and the services never followed into the community, and therefore our jails and prisons became, and the competency to stand trial system became the new suck in to get and access mental health or behavioral health care. There's major risk if we don't do this. Right? There's major risk, not to the individuals that we're serving, which is major, but even for our jail and law enforcement staff. We know that inmates with mental illness are likely to spend 2 to 5 times more time incarcerated than their non-mentally ill peers, right? So if you're a jail staff member and you're like, man, I really want to get these people out of my door, there's a good reason to make sure we're providing them quality care to get them out, get them connected where they need to be. You're also more likely to be injured by them. They're more likely to be injured by themselves and by our law enforcement responses as well by being in that space. So again, I think just kind of framing out to you or laying out the legal underpinnings for why we want to do this beyond our morals or systemic or quality of life reasons. And again, I'll sort of tease this last point before kicking it off to Flowstate. You're going to be, we have some other sessions today and tomorrow on the sequential intercept model. It's likely to be an introduction for some, a refresher for others. The one thing that I think is interesting that I'll just leave with you is to appreciate the authority and the discretion that a lot of people have across that continuum to move people out of this system, deflect them away from this system, or divert them to someplace better if they're caught up in the system than we utilize. And that can often seem odd because these people, yes, they are engaging in illegal acts. They're causing danger to the community. They're frustrating people in these public spaces. Yet, if we really can embrace those ideas about where does this person need to be to get the care that they need, which will reduce the risk surrounding it, including maladaptive behaviors or illegal activity, thinking of that as we talk about that sequential intercept model might open up some ideas across our system, so ways that we can embrace deflection, diversion, and also make sure we're being really good stewards of our resources in these different intercepts, so people can ultimately get out and get connected with the spaces that they need. But with that, I'm going to pass it off to Stephen Slye, CEO of Flowstate Health, and Michelle Vore for their talk more about their experiences and their model. Thank you.
All right, well, a little bit about Flowstate Health. So, company was founded just about 4 years ago exactly, and we started very humbly with 3 hospitals and 3 county jails that we worked with. So, Dallas, Audubon, and Guthrie. And fast forward to today, and we're in 33 critical access hospitals and 57 county jails with a waiting list of 5 additional county jails to join on with our services. We also do some special programming with Molina Healthcare of Iowa, with Delta Dental of Iowa. In all cases, kind of what we're doing is trying to get services to folks faster, really looking at ways we can do things better systemically. So I'm here today to talk about our jail-based behavioral health services program. This initiative is more than a new program. It's an opportunity to create a unified statewide model of care for justice-involved Iowans. So for too long, access to behavioral health services in Iowa's jails has been inconsistent, fragmented, and determined by geography, rather than where people need. So as we were getting to work around the state and establishing our services, we would run into situations where we'd be in one county and they had lots of different services, they were well funded, things were built out, and then if you drove 30 miles in any direction, they had basically nothing. And so that's a huge part of our work, is to make sure that there are basic services that all jails are receiving equally. I'm going to outline how we've begun to translate our vision for fixing this system into action, and we're using a practical framework to move from responses that we've picked up in our research to a coherent outcome-driven system that improves lives, supports jails, and strengthens our communities. So, the problem we face is systemic fragmentation. Historically, whether an individual received timely behavioral health care in jail depended less on their needs and more on where they happened to be incarcerated. Some counties had strong programs, but many did not. This inequity resulted in inconsistent care and significant gaps. Instead of proactive preventative services, we saw reactive responses that often escalated into crises, and we also work with the jails on the crisis side. So Michelle will talk a little bit more about that. That system was not designed to catch people early and to stabilize them and connect them with long-term care. It was designed to respond once things had already gone wrong, and that model is costly, it's ineffective, and it is unjust. Looking closer at systemic failures, authorization processes delayed care, leaving people without services during critical windows of need. What that meant is in the regional system, oftentimes a pre-authorization process had to take place before somebody received care. And by the time that authorization had been done, that person might have already bonded out of jail. So similarly to the description earlier of how IAPCA has been able to get people paid faster, we are able to get services to people faster. in most cases. So, again, that was inconsistent across the state. Some counties were requiring, some regions were requiring this pre-authorization, some weren't. So that's not universally true, but by and large, just in general, we don't have to go through that anymore in our model. The downstream effect was predictable. Relapse, disengagement, and reincarceration. This made costs higher for counties, hospitals, and communities, and emergency rooms, as we've heard throughout the day, shouldered the burden of a system that waited until the point of crisis to intervene. So, with our model, we are focused on standardized protocols to ensure that regardless of where someone is incarcerated, they are screened, assessed, and treated in the same evidence-based way. Robust data collection that we're working with Iowa PCA to standardize allows us to measure outcomes consistently and compare data across counties in a similar way. And at a systems level, can guide continuous improvement. So we believe that running the same model throughout all county jails or throughout most county jails, when that person goes back into the community, and we'll talk about justice navigation here in a bit, if we run the same playbook everywhere all the time, we're going to see results about follow-up appointments and recidivism and things of that nature in a detailed, specific way that we weren't able to track in the same way previously. So these three elements, standardization, data, and transparency, will transform a set of services into a system that can demonstrate measurable impact. The model is structured around 5 essential functions: screening, assessment, diagnosis, treatment, and navigation. And together, these functions create a seamless continuum of care. This will ensure that no one slips through the cracks. Assessment will provide depth and clarity about needs. Diagnosis will ensure accurate, evidence-based care planning. Treatment will deliver the services people need when and where they need them. And navigation bridges the gap from jail to the community, preventing gaps during reentry. These 5 functions are simple, scalable, and when combined, create a powerful model for behavioral health in jails. Screening begins at intake. Every individual entering custody receives a behavioral health screening using validated tools like the BJMHS, the audit, the DAS-10, and the brief biosocial gambling screen. This universal process ensures consistency. When screenings flag urgent needs such as suicide risk or acute withdrawal, triage occurs immediately. This step transforms intake from a procedural task into a potentially life-saving intervention point. And so, as Flowstate is building these services out across the state, screening, this universal screening process is something that is still very much, we're still working on it, as you can imagine, with the jails, and we are going to be using some of our opioid settlement funding dollars to do so. But it's a real challenge to get every jail to run this process consistently throughout the state. We're getting basically universal cooperation and interest in doing so, but it will take some time. So we'll talk a little bit about justice navigation later. In terms of screening, that's another thing that's kind of in process that we're working very hard to get online universally as quickly as possible. When a screening indicates elevated risk, we move into assessment. So basically, this person's been found to need services. This stage uses comprehensive evidence-based tools like the PHQ-9 for depression, the ASAM for substance use, and the trauma history screen. These assessments provide depth needed for individualized care planning, and they also generate standardized data that feeds into both clinical care and system-level reporting. Assessment ensures that we are not just identifying problems, but also structuring effective data-driven responses. So what this means is that we are going to have a statewide understanding of how screening is leading to various outcomes. Recidivism, how quickly people are seen out in the community, are they getting to their appointments, things of this nature. Diagnosis is the next step. It's essential. Licensed clinicians, in our case, mostly psychiatric nurse practitioners, psychiatrists, licensed mental health professionals, review screening and assessment data to make evidence-based diagnoses. This process ensures individuals receive the right interventions for their needs. It also strengthens compliance with reporting standards and aligns with best practices in behavioral health care. And diagnosis is transforming data into a care roadmap. Treatment. Treatment in the model is comprehensive and it is consistent. It includes psychiatric services, therapy and substance use treatment, ensuring a full continuum of care. Telehealth is used strategically to reach every partner jail, regardless of size or location. Services are evidence-based and outcomes are tracked continuously. By expanding treatment beyond psychiatry to include therapy and substance use services, we move toward a truly integrated model of care. Prior to this model, throughout the state, mostly what you would have is psychiatric services by and large. Pretty much every county jail had access to psychiatric care. Very few had access to substance use and therapy services, at least not in any coherent way. And so a big part of what we're doing is driving use of of therapy and substance use services and treating this as an integrated model of care. Justice navigation. So we've talked a lot about system navigation here today, and a lot of the questions that have come up can kind of relate back to our justice navigation function and where it will plug in. Navigation, justice navigation, it's the bridge between the jail and the community. So we have recently hired our first 2 justice navigators. We are continuing to hire those people out similarly, still hiring. And what these folks will do will ensure that individuals have benefits reinstated, appointment schedules, and medications bridged at discharge. So in the past, again, all throughout the state, you had different versions of this thing. And what we are aiming to do is to run this playbook consistently throughout the jails. So they will coordinate across systems, jails, courts, hospitals, and community providers, to ensure continuity of care and reduce the relapse, overdose, and reincarceration risk during reentry. So old system, for instance, up in northwest Iowa in the regional system, we were able to do this with some counties up there, and it worked extremely well. So we've taken what we've learned there, and we're rolling them out throughout the state in a more planful way and more universal way. So kind of key functions of the Justice Navigator for jails. First point of contact and a go-to person for behavioral health needs. So you're a jailer and you have a question, you need some help, you will have a person that you can reach out to and know exactly who to contact every time. Sounds pretty basic, but again, we're moving from a patchwork where that was happening in some places to making sure that it happens in all places Flowstate is at. A designated lead to identify inmates in need of services, connect them to appropriate care, and schedule ongoing support. So we're providing psychiatry, therapy, substance use services. These navigators will help the jailers understand which inmates need which services and make sure they get matched with them and they get scheduled. A judicial liaison to bridge communication with the courts, particularly around commitments and placement into treatment programs. So a focus person, again, old system happening some places, now happening sporadically, but we are going to make sure that the jails that we work with have this person regardless. A community reentry specialist to focus on continuity of behavioral health care, psychiatry, substance use, and therapy, while also connecting individuals with primary care and supporting medication management until the next appointment. So when somebody leaves jail, we're really honing in. We had work called jail diversion before, or different things in different parts of the state. We're really honing that work in, honing those roles into making sure that that person leaves with a psychiatric appointment scheduled, a substance use appointment scheduled, a therapy appointment scheduled, and then also adding in primary care as something that we're really focusing on, and bridging them with medications until that psychiatric appointment if that's what they need. Justice navigation is the glue that holds the system together, the difference between episodic treatment and true ongoing recovery. The key benefits of this model: it delivers proactive, person-centered care. We're shifting from crisis response to earlier identification and timely support. By enabling seamless reentry and continuity, it bridges jail-based and community services so treatment continues without interruption. The model strengthens collaboration with jails and courts, aligning efforts across corrections, healthcare, and the justice system while embedding transparent data and accountability through real-time reporting. Together, these benefits functioning will create a system that is more equitable, effective, and sustainable. Year one deliverables. In the first year, our work is focused on strengthening the foundation of care. We are expanding direct services with a particular focus on growing therapy and substance use treatment alongside psychiatric care. We are working to reduce reliance on crisis-driven responses and ER transports by identifying needs earlier, ensuring people are seen faster. This is something that we were able to prove out in our work prior to adding a lot more jails on July 1st, is that we were able to drive down those crisis responses by working more holistically with the jails and with the hospitals. And so we're now working to take that work into more jails. We're improving medication access at reentry, bridging individuals to their next appointment, and helping ensure continuity of treatment. At the same time, we are strengthening training for law enforcement, equipping officers with tools and strategies to respond more effectively and compassionately. Together, these efforts are building momentum toward a more seamless and responsive system. So, where are we at currently? We've been doing this since July 1st, so that's just a little over 2 months. We are operational in 54 of 57 contracted jails. We've had 5 additional jails reach out to us through recommendations by their local law enforcement wanting to start services with this program. So the feedback has been excellent from the sheriffs and the jail administrators themselves. We have delivered about 600 direct care appointments. The vast majority of those are psychiatric services, which still remain by far the most common. We are working to, as I've talked about, focus more on therapy and substance use. We are working to improve medication access at reentry, ensuring continuity of care and bridging people to their next appointment. And we are working with jails to strengthen law enforcement training, having to implement and explain best practices, the things that we've seen work in other jails, that if these jails adopt, they will get a higher quality service for their inmates. Next steps, we are working to pursue the implementation of EPIC as our organizational EHR. This is going to enable real-time data sharing as individuals re-enter communities. We are working with jails and management companies to standardize things like suicide watch release protocols to ensure consistency as we move toward a more statewide system. We have these management companies in about 20-25% of the state, and really having to suss through things as simple as suicide watch protocols, which even within the same management company are being done differently from jail to jail, which is just unfortunate, but something that we are focused on making consistent. Justice navigation is being further built out with navigators assigned to every jail every partner jail to support the things we talked about, inmate identification, coordination with the courts, and guiding reentry planning. And then universal screening is also being installed at all partner jails to improve early identification and intervention. So, 600 services already. You got to think we had 34 jails when we started this. We're at 57 now. So we think that, that's a lot, and we think the therapy and SUD, it's ramping up extremely quickly. We think by the time this program's fully implemented, if it goes the way that that it has so far with all this support, organic support from the sheriffs, that we're looking at doing something like 30,000 services a year when this thing is fully online. And we're on track to do so far. All right. Well, Michelle Vore is Flowstate's Chief Operating Officer, and just can't say enough about Michelle. When the service first took off, or when Flowstate first took off about 4 years ago, it was really when Michelle and I connected, and I'm glad to introduce her.
Change of plans for me not to stand up there. They just asked me to sit here since we're kind of getting into discussion. So I have to I'm a talker if you knew me, so give me some grace that I have to kind of run through some of the key points here, just because we started a little late, and I think we underestimated some of our time, so I apologize for that, my short spiel here. But just to kind of hit the key points, when I started the jail-based program, I was very passionate about making it an outpatient service. This population already have a history, most of them, of abandonment, trauma, and so that continuity of care was really important to start that right away, build some trust, and then we also wrapped around a crisis service around that. So they have access 24/7 for crisis access for a crisis team. So that's been really rewarding. We started with 3 jails, and I know one of our biggest first jails was really skeptical, thinking telehealth, we had to really prove ourselves, which was a great reward to kind of come out and have them actually be one of our fans, and to see that we can increase access to care and do it very well, even if it's remote. Now with that, I really developed a importance of collaboration. We really need a good pre and post huddle, which, gosh, now I have them asking me, where's our huddle? I mean, they really recognize the importance of that, and that's instilled in our hospital-based program and our jails too. So we really can't do it without that proper communication and having collateral information. And then also with that too, I think it's really helped. I've seen even more referrals from the jails, just because we've actually instilled hope within the jail, like the culture of these jails. So I really that's those extra rewards later, like, wow, we are doing the right thing. It's a challenging population. These people can be easy to cause a lot of frustration amongst the jails. So I really have to give a shout out to law enforcement. I see them throughout. Most of them are bringing them to the hospital, supporting them there, having to support these critical access hospitals. They manage them in the jail. I mean, they're everywhere. So I really have to give a shout out to the law enforcement. And then for managing the patients in these jails, I just wanted to really specify all these jails have different capacity and what they can offer. All the sizes are different. I'm from rural community. I was a critical access hospital nurse. I've been at that bedside with very limited resources, a 5-bed ER. And then I did go on and had the opportunity to be a behavioral health consultant through Allen. And so that was a 5-bed just designated for those, a locked mental health unit right in the ER. So that was a great opportunity to wear that hat. I wanted to learn not just how to assess crisis, triage, but I wanted to know what's next. What's next after we stabilize them? We decide where that level of care is and coordinate it. So we instill that through everything we do. And I think that's really helped us grow. I'm surprised Stephen didn't mention our website's there. It's just not opened. We've just been growing by reputation. And honestly, it's just unexpected to say, gosh, all we're doing is really just trying to be holistic in our approaches, common sense, collaborative. It's been a challenge to serve throughout Iowa, really spread out, but at the same time, been able to really see a lot of great things going on out there. And gosh, if I could take a little bit of all this and shake it up in the middle, and there's a lot of great things that have been happening, but there's also been a lot of inconsistency. And so we've been looking forward to develop, just go statewide and get all these jails, if we can even start there, because right now we see county to county transfers, and boy, some of them take a while to get it's taken too long to get to us. And we see that. They can decompensate very quickly. So it's been a really reward just to get there quicker. We talked about early intervention. I know a lot of these folks have been struggling a long time, but if we can get them quickly in these really acute states, keep them out of the ER. And so that's always really a big goal, is to keep them out of the emergency room. But if they have to go there are times we're very collaborative, and we try to do the assessments in the jail if we can. It's less stimulation, it's quieter if they're safe enough. I've had to intervene and really guide the jails to say, no, they had too serious of an attempt, that they need, cervical spine interventions, things like that. So those are those cases that they can't be. But it's actually really been helped with the burden on the jail staff to bring them to the hospital if they need. And then if they go there, we collaborate. It's been really helpful if we serve the critical access hospital and the jail both. So then we can manage them, and everybody moves quicker. It keeps the time in the hospital shorter. But I've also seen some not go well when people try to move too quickly and get them back to the jail. So those are things I feel like we do really, really well. If we can help steer that, we're kind of the gatekeepers, I call us. Really help be protective of the hospital and the jail both. The EMTALA violations, like the medical piece, we have to really treat and slow down. People have gone back to jail too soon, and I've had to kind of intervene and say, whoa, we thank you for your, getting them there and giving that support. Sometimes it's because they needed just an injection, just to get their level of psychosis, anxiety under control, not as a restraint, but just because of the quality of life and they're deteriorating. But don't go back to the jail too soon. Okay, those are those safety things we really have to be aware of. These aren't big jails. They don't have always nurses on staff. They don't have the medical capability, sometimes even to do a blood pressure, check a heart rate, things like that. So those are some safety things that I would share that I've really had to guide and be part of. And that's what we're really known for. I think we've really built that trust. So if we don't serve the hospital, we're still collaborative. And I've had really good experiences when they are willing to work with us as well. That prevents another psych assessment, then another change of meds. And sometimes what doesn't go well when those things happen that I found, they get an assessment from a hospital, they come back, there's no warm handoff, that's really kind of given back when they go. And so we've actually seen, it was recommended for medications to be started. Psychosis is pretty easy to treat. Let's get it going right away. Well, those kind of things, it was missed. And so that's where I feel like we've really been able to keep people from needing inpatient care. We've been able to get to them and provide better care quicker. But it really does take a team. Being spread out throughout Iowa, I can say, it used to be by region, as we know. So each region, I can kind of say each experience is a little different. And I can't wait for the day where I don't have to treat them for, they're in this jail, they only have access to these, or I'll have, we're calling them kind of navigators now, so to say, but each jail kind of had their own justice coordinators, jail advocates, whatever they were. They all had them, but they all functioned differently. So I just can't wait for more continuity of that and more accountability. But we also have to be mindful that each jail has different needs. And so nurses, for instance, they may have them, so that's we have to adapt to that. And then public health, I will give a shout out to some of them. It's been really rewarding. Some of these jails we visited recently, we've had public health show up for the community. We've actually had a hospital show up. Everybody, those are good things I want to share. That's great. Because I've also still in the middle of where jails and hospitals don't get along. And that's where dangers happened. They get sent back too soon. I've had to advocate to say they're not medically stable to be there. If they could take a blood pressure, it was sky high. This person's symptomatic, probably going to have a heart attack or stroke. Those are some unsafe things because they're just wanting to move them out too quick. So I can't say enough as far as those are so easy to modify. And so just want to bring that to the attention. And then there's also a shout out to some places that I've been a part of. We have a hospital that meets bi-monthly, and their magistrate are there, their law enforcement, their hospital team. I have another county that I join it's every 2 to 3 months, but they actually include their law enforcement, their community-based clinic staff, IRSH level home that we manage in that hospital. Those are really cool things I just want to share. A lot of good things going on out there. I know there's many more, but that's really been helpful to wrap arms around these challenging situations. Because when we all try to just pass them off quickly, that's where we're really missing some opportunities for better quality of care. So that's how we've grown, just simply have a little empathy for where we're sending people to, putting ourselves in their shoes, good collaboration, and just simply holistic care and evidence-based. So I could go on and on, I just can't. Because of time.
We got just a few. I think we can. Thank you. Thank you, Michelle. We have just a few minutes left for some questions. Leslie, I saw your hand already. Here they come, I think. I see the microphones getting ready at the back of the room. But if you... Yeah. So Leslie's question is, how are we paying for this? So the model build that we're talking about today is dollars that are coming through the state. There are still counties that are paying for work that's happening within their jails. Sometimes it's both, right? So sometimes the spaces where we have some of these state dollars that are invested in the mix, the county itself also still has money in the mix, because the way our code reads today, of course, is that the care for folks that are within our jails is ultimately something that happens under the responsibility and the accountability spaces with our sheriffs themselves, which is why we were having those conversations. It actually says the patients are responsible for the cost of their care. But what we find over the course of time is that, of course, these are oftentimes people that they're not going to be able to pay, and this is such a crucial space when we think about behavioral health care. It was a spot that regions were invested before. That was some of that dollars information, and we've now put that pooled money together in order to build out modeling. Yes. Clear up here. I always think that I'm loud too, and then they still make me use the microphone.
Thanks. Hi, I'm Julie Smith, and I'm the director at Capstone in Newton, and we're a community mental health center. So we have been providing jail services since 2017. We have a clinical psychologist that goes into the jail that does assessments, and we also have my substance abuse counselor, Jade, is here. She also does evaluations, ASAMs, all of those things at the jail. Jill is my case manager, and she does. I love everything you're talking about. I'm like, this would be great if it was uniform. But then Jill's sitting here going, "Am I going to lose my job?"
Sure. Yeah.
So I mean, so it's great because one thing that we've really prided ourselves on, especially the last couple of years, is that we have increased our housing in Jasper County, and so we work so close with. I can't say enough good things about Jasper County, about law enforcement, about the sheriffs, and about even our local police and our county attorneys. They assist us, and we, get people. Jill literally picks them up when they're released. She brings them to the mental health center. They've already had an intake, so then they're able to see the med provider and get on their meds. So I do think that we have a really good continuity of care. My question is, will you guys come in to do that in all of the jails, or since we're doing that and it's not broken?
So Abby's over here, right? So one of the things that we think about as we're thinking about what installation looks like is that we have some counties that had a concentration of resources, and we had a lot of counties with nothing. Right, and we're trying to figure out how do we get to statewide modeling that ultimately leverages the things that we can leverage, right? Human time is hard. You guys know this because you're doing it in real time, right? Human time is hard. It also has downtime. And how do we leverage the modeling that we have where we get to a space that we get to spaces that are consistent, right? And we have the ability to be able to use tele, for instance. And then there's still plenty of work for all of us is the other thing that we know, right? There's no shortage of work and there's no shortage of people that need us in this world. So we don't know what all those answers are going to look like yet. How do we get to the installation of a statewide model, particularly in a space where we're thinking about, this is also a space that is going to probably always and forever exist in mixed funding responsibility. Right? We're going to be able to do what we can do from a statewide level, and there's still going to be a need at a local level that is ultimately determined by local levels of decision making. And so we don't know the balance either. We're going to figure it out. I'm kind of excited to do that. We also don't know where all of it exists. I'll just be honest with you, right? We're still picking pieces up and just trying to stitch them together. But the potential, I think, is really, really significant. I did know that you all were doing it. I have enough to know that.
Yeah, I serve on the governing board for CICS region also, and so we tried to make it where, they tried to move it towards the regional concept, and our sheriff's office was like, no, please don't take Capstone away, because we do provide, we provide an intake within 48 hours, and we utilize telehealth as well. So we do provide an intake within 48 hours, and Jill is out there if someone comes in and is needing, the coordination of care and the navigation. I like the word navigator. I just told her I was going to change her job title. but we do work really well with that. So I'm excited to see this happen, because we do get people transferred a lot from Polk County, because Jasper County holds Polk County. And so we get a lot of those people, and some of our funds that we use for our substance abuse evaluations are local opioid funds that we use for a grant. And so we're not able to see those Polk County people, so they're like, well, why? So it will be good to be able to, work together to make sure that everyone has the same resources going forward. So.
Thank you. Maybe a last question, Lori. How am I doing for time? Lori's my timekeeper.
I just want to give a quick shout out to Flowstate. We make referrals. I work for Molina Healthcare, and we make referrals to you guys all the time. And our patients, our clients, they love you guys. So, yay! Aww. Thank you.
I just want to know how you're getting to the hospitals and the jails. Like, how is that happening? Because I'd love to see this in Iowa City.
In terms of how we've built business, it's been almost completely organically. So a week ago today, I got a text message from Sheriff John King up in Palo Alto, and he had been at a sheriff's conference that day, and he was just texting me to let me know that he had a meeting that day and had let 2 of his sheriff colleagues know about our program and that they were going to be reaching out to me. We have 5 additional counties lined up to start maybe on January 1st, and again, those were folks that have reached out to us. I've actually talked to people at Johnson County, and we think that we'll see them at jail school. So yeah, we're excited to learn more about the organizations that are doing great work, it sounds like, and also to connect with the Johnson counties and hopefully bring them in as well.
I'll surprise Stephen by saying that there's a systems of care meeting that happens over in the Iowa City area that I had the opportunity to join just recently. I'm not going to be able to be there next week, but maybe something that we can do is by the time we hit October or so, maybe we'll see if we can bring some of the Flowstate folks along to that too.
Okay, thank you very much, Marissa, Dr. Hess, Stephen, and Michelle. That was a really good conversation, and we have a ton of questions that came through the website, so we'll definitely respond to those and get those out to you guys on the website as well. So we're going to take our lunch break, and we've got a buffet style out there. You can go down both aisles of that, and we have Chief Justice Christensen on her way here, so once we get settled back in here with our food, then hopefully she'll be here by then and be able to give us a midday address. So thank you.